Good morning, everyone, or good afternoon, depending on what part of the world that you are. I will be facilitating this session this morning on malaria governance. Governance is a very complex concept with many different definitions. One simple definition is how society or groups within it organize to make decisions. This includes the importance of authority, decision-making, and accountability. Who has power, who makes decisions, how players make their voices heard, and how players are held accountable. These core considerations of power, decision-making, transparency, and accountability shape our approach to rethinking governance related to malaria. Today, we're going to have two amazing speakers present their work on malaria governance, and then we're going to also have two discussants. First, the presentation is by Dr. Nee Ayite-Coleman. Dr. Nee Ayite-Coleman is a consultant in health systems policy, financing, and governance. He is a former director of policy, planning, monitoring, and evaluation at the Ministry of Health in Ghana. He also served as an advisor on health systems, policy, and financing to Ghana's Minister of Health. Dr. Nee, over to you. If you have any questions, please put that in the comment box and we will try as much as possible to get to all of them. Thank you. Dr. Nee?
Thank you very much, Ify. And I'm very happy to be part of this workshop. And to introduce the discussion on the engaging communities and local authorities in national malaria programs. The goal of global malaria agencies and global malaria programs is to eliminate and eradicate malaria. Eliminating and eradicating malaria requires each of the endemic nations to eliminate it in their countries. As we rethink malaria, the critical question for African countries where malaria is endemic is whether our national strategies are adequate to eliminate malaria. So whether whichever part of Africa you are, east, west, south, north, whatever country in which you are, as we rethink malaria, the crucial question is for you to ask, is my national malaria strategy adequate to eliminate it? This presentation would look at the case study of Ghana to highlight the key findings in an assessment of the adequacy of Ghana's malaria strategy. Ghana is an endemic malaria country. It is classified as in the malaria control phase. The high disease burden, 40% of OPD cases are due to malaria. The Ghana's national malaria strategy is articulated in the Ghana Malaria Control Program strategic plan for 2015 to 2020. And the thrust of that strategy is to accelerate progress in controlling malaria in high transmission areas, and then to make moves to establish low transmission areas. In other words, malaria transmission is high. When we examine Ghana's strategy, we see that it is basically medically oriented. Predominantly, it involves diagnosis and treatment of malaria. Of course, we have distribution of insecticide bed nets. We have some form of vector control, predominantly very selective larvicidin. When we look at the strategy as a whole, we see that there's very limited engagement with significant section of stakeholders. There's little community involvement, and the multi-sectoral action is very limited. But we know from the epidemiology of malaria, that is the determinants and distribution of malaria, that social factors such as lifestyle and environment have significant impact on malaria burden. So malaria, more or less, is a social problem. And interventions must address the social determinants of malaria, i.e. lifestyle and environmental factors, so as to control breeding of mosquitoes. Progress towards elimination will require redirection of Ghana's malaria strategy. Treatment, diagnosis and treatment has been very useful. We have seen a very big drop in malaria-specific under 5 mortality from 14.4% in 2000 to under 1% in 2012. So that is a very important component of the strategy. But in order to deal with the indiscriminate breeding of mosquitoes, we must promote multi-sectoral action and expand the vector control component. But more importantly, Ghana's strategy requires a systematic rethinking to mobilize participation of communities in the governance of malaria. So how do we mobilize communities in the governance of malaria? We are saying that there are multiple stakeholders at the district level. Besides the Ghana Health Service, we have the private sector, other non-allopathic practitioners within the district health system. There's the district political system, the secular political system, the assembly and its elected members. There's the traditional political system, and even in the communities. So what they are saying is the malaria program must engage with all these key stakeholders in the district in a systematic and sustained approach in order to strengthen multi-sectoral action and community participation. This will require new accountability relationships within communities and between districts, district assembly, district health authorities, and communities. This is nothing new. We are asking to restore to malaria program the key elements of primary health care, intersectoral collaboration, community participation. That is what is missing in malaria program now. We believe that malaria programs in other African countries need to similarly redirect towards community health governance to engender progress. Let me conclude by saying that the goal of elimination and eventual eradication of malaria without effective control of mosquito breeding and public health regulation is fundamentally flawed. Any progress that we make towards malaria elimination will require a paradigm shift from the current medical perspective to a social determinants approach, where we engage stakeholders in a sustained and systematic manner, especially the local communities. The global malaria agencies must also redefine malaria as a social problem and collectively adopt a social determinants approach to the development of national malaria programs. In conclusion, what I'm saying is malaria programs should be reintegrated into primary healthcare at the district level. Primary healthcare at 8, later 9 elements, one of which is the control of endemic diseases. Malaria has jumped out of the primary healthcare and is isolated. It should come back to primary healthcare and help to strengthen community participation, to improve it into community governance, and help to strengthen the health system as a whole. Thank you.
Dr. Lee Coleman, for that amazing presentation. I'll just wait for the audience to ask questions, but whilst we wait, just wanted to ask a question. So in your paper, you suggest that we move away from the current practices where the NMCPs decide on the standard packages of interventions, which is driven by donor preferences, implemented from top to bottom, to a practice where the district level makes the decisions. To achieve this decision making, it requires a lot of changes in the structures, the roles, and also responsibilities of the NMCP and the district community. How do you think we can realistically achieve this, considering the current structures that has been in place for a very long time in Ghana's health system?
The most important thing is for the global agencies to acknowledge that malaria is not a disease, just a disease. It is a social problem with social components, lifestyle, and environment. Now let's go. So it's not purely about shifting decision-making from the top to the bottom. As I'm saying, it's about building on existing structures, existing strategy in Africa for more than since primary health care. And that is, we develop our health system around the concept of primary health care, and that entails the participation of communities. So all we are asking is nothing new. The old structures of primary healthcare, village health committee, we need to redesign it and turn it from a passive management committee into a governance strategy, a governance body, where all key stakeholders at the community participate in it. They should be part of the, we are not eliminating the medical people. We are asking to bring other stakeholders on board for collective decision making.
Okay, thank you so much, Dr. Nick Coleman. I will move ahead to the second speaker, and once I introduce him and he presents, then we go over to the discussant, and then we have other questions from the audience. Our second speaker under this session, first session on malaria governance, is Dr. Jesse Bump. He will be presenting on decolonizing malaria governance. Jesse Barb is an executive director of the Takimi program in international health and a lecturer on global health policy at the Department of Global Health at the Harvard School of Public Health. Dr. Jesse Bump, over to you.
Thank you, Efi, and thank you everyone for joining us. Thank you, Nii, for those wonderful remarks. I am delighted to be here with you today, and I'm here to speak on this topic of decolonizing malaria governance. So I will share my screen briefly. You can see my slides here. This is a paper joint with Dr. Aniebo, who is our moderator today. It is called Decolonizing Malaria Governance, and it comes from a discussion that she and I were having. In part, that was a discussion in its most recent form that was inspired in April of this year on a paper that she and some other co-authors had written. There was this $30 million grant from the US President's Malaria Initiative that was supposed to support malaria data generation for decisions by African governments. And their paper pointed out that none of the recipients were African institutions, let alone African governments. Meanwhile, they observed that 99% of malaria research funding goes to non-African places, and just 1% goes to African institutions. Meanwhile, 94% of all malaria cases and deaths are in Africa. This imbalance struck us as remarkable and noteworthy. I'm a historian. You can read my biography on our website. We won't take too much time on it, but I'm a historian of colonization, post-colonialism, decolonization, global health. And Efi and I began to talk about this. We began to talk about the long-term patterns and the long heritage of slavery, colonialism, extraction, and disease. They're all bound together in the heritage of global health. We had these questions that you see on your screen now. Why don't the centers of malaria research migrate towards the actual malaria? I would suggest that perhaps every African mother knows things that most malaria researchers never know. Why does global health focus on so few anti-malarial strategies? Why is malaria in Africa such a focus for international actors, including academics, foundations, and donor agencies? And why aren't Africans, with the vast majority, 94% of malaria cases and death, why aren't they leading everything? These were our questions that led us to this frame of decolonization. And we looked at ourselves and we thought, well, colonial extraction is alive and well. Here's a diamond mine, the Wesselton diamond mine in South Africa from 1905, still going on. Here's Firestone Rubber in Liberia, operating there since 1926. And here's a book, An Expedition by Harvard to Liberia and what's now the Democratic Republic of Congo, then the Belgian Congo. And it's like, well, that's still going on too. So we decided to look into it. In global health, there's been a recent literature about decolonization, and primarily it's been commentary and opinion. So we decided to look at historical facts to try to figure out, how did we get here? What was colonialism? And it's hard to explain all this in just a few minutes, but the basic depiction of colonialism, its basic purpose, was to generate unfair trade advantages for shipping firms and other Western companies that had lost business with the ban on the slave trade. The primary obstacle to that was malaria, because Europeans just couldn't survive in Africa. They couldn't enter the interior to trade. And so they started trading with intermediaries, and they started making deals with chiefs to try to extend their role and gain unfair advantages for the private sector. That's the root of colonization. This is a picture of the mortality of European troops in the early 1800s. And you'll notice each bar is deaths per thousand, 100 per thousand. So in Sierra Leone, the annual death rate for European troops, so these are well-nourished, fit people in the prime of life from European countries serving in the military, which has complete control over their health and behavior and nourishment. The annual death rate is around 500 per thousand in Sierra Leone. So this gives you some sense of why malaria was so important. It was the #1 problem and the #1 obstacle to colonization. After the invention of what I'll show you in a minute, tropical health, tropical medicine, the scale here now is deaths 20 per thousand. And you can see that over the course of about a century, mostly concentrated on progress later in that century, Europeans had figured out how to defeat malaria for themselves. So tropical medicine is the field that emerged to do this. It focused almost exclusively on malaria. It began in colonial government services in the 1880s and 1890s, but then the leaders quit in search of more pay and more prestige, and they chose to organize themselves into new internationally oriented schools. They weren't domestically oriented, so they didn't get connected to the basic public health functions of Western countries. They had an international reference so that they could support each other. So the links weren't down domestically. They were based in the metropoles. I've given you a few dates here. Almost all the primary schools were founded in about a decade, starting with Liverpool in 1898, which was the capital of the shipping capital for the slave trade. Then London, which was the #2 shipping port for slaves. And then from the rest of the continent, 1902 was Lisbon, Antwerp, what's now the Institute for Tropical Medicine there, 1906. The US was a little later, Tulane in 1912. Nonetheless, these schools of tropical medicine emerged as the focal point. It emerged as a new community that would study malaria and other diseases associated with colonization. The schools sought funding from governments and from the private sector, and they promised to facilitate extraction. When the London School of Tropical Medicine, hygiene was added later in 1924, but when the London School of Tropical Medicine was founded in 1898, the colonial secretary presided, saying the fight against tropical disease constitutes the real basis of the politics of colonization. They emphasized narrow management strategies and not development strategies. So if you consider the way the English themselves vanquished malaria, which used to be common in the South, or the way the US defeated malaria in the Tennessee Valley area or around Atlanta or major cities like New Orleans, it's mainly a mix of generalized development like improved nutrition, improved housing standards like screening the houses, draining swamps, improving agriculture. The history of malaria shows that industrialization of agriculture almost always gives a vast advantage to malaria temporarily. And then general living standards improve. People screen their houses, they protect themselves, the parasite slowly disappears, and then malaria is no longer a problem. But in Africa, ending colonialism, which was the primary engine for malaria, was not an option. So they turned to small strategies, to very narrow interventions. It was designed to support colonialism only by managing its effects, not to end it and not to promote health. So we return to our questions from the beginning of why don't the centers of malaria research migrate? And the reason is they were designed to extract. They weren't designed to support health, and they weren't designed to respond to the needs of native or indigenous people. Why does global health focus on so few strategies? Well, it's no surprise to us in historical perspective that the two strategies preferred in global health are private sector products, drugs and nets. No swamp drainage, no screening of houses, no generalized development, no investment through progressive taxation or taxation on extractive industries. In general, these two narrow strategies favor private sector businesses that aren't based in Africa or other malaria endemic areas. Why is malaria in Africa such a focus for international actors? Well, it always has been. Malaria in Africa has been powering careers in the West for over 100 years and is still doing so successfully now. Why aren't Africans, with the vast majority, 94% of cases and deaths, leading everything, from which we might mean programs at the international level, domestic programs, international consortia? Why aren't they? And the reason is that global health was designed, it's a direct descendant of tropical medicine, and it was designed to facilitate international careers for colonizers themselves. And it's still doing that. So this isn't a statement about the values of people who are now in global health. It's merely a statement about the continuity we see between tropical medicine, colonization, the management of malaria, and the ongoing inability of global health to really solve the malaria problem. We believe the answer lies in something of a paradox. Decolonizing malaria governance is at once a call to enfranchise people from communities that have malaria and to advance people whose lives are most affected by it. But it's also a call to dismantle colonial structures that inform virtually everything about our current approaches to malaria. So there's a great deal to discuss. I thank you for your time and thank you for the opportunity to present our work.
Thank you so much, Jesse, for that amazing presentation. I would like to invite our two discussants. First would be Olivia Ngu. I would like to invite Olivia to have comments, to give comments on Dr. Ni Aida Coleman's presentation. Olivia is the founder and executive director of Impact Santé Afrique. Olivia, over to you.
Yes, thank you very much, and thank you for the opportunity to give a few feedback, and thank you to the speaker for those amazing presentations. Just a quick comment about malaria and community health governance. Yes, I really agree with all the points in the papers. I think, yes, malaria should be reframed in the context of primary healthcare. But I also think that it's important to also think about investment, because community health governments, in order to be effective at the community level and practically, we also need to make sure that in the budget line for the malaria program in the strategic plan, that investment in those community systems is also a priority. Because like the speaker said, the expertise is there, the systems are there, and malaria needs to definitely shift from a medical approach to a social approach. And this means that we have to now look at all the barriers, and then we have to think about why are people still dying from a disease we can prevent and we can treat easily. And if the answer is about access, is because they don't have access to quality services, then it means that we need to also think about how to increase accesses for those vulnerable communities and population. And I will also insist on the word quality, because it's not just about distributing mosquito nets or making sure that there's treatment or testing available, but it's also looking at the quality of those mosquito nets, the quality of those testing and treatment, and the quality of the tools that are actually arrive at the community level. So it's important to have the community system in place to increase malaria or even health community governance. But in order for all of that to happen, we have to also, I was just wondering how many countries in Africa have community system or community actors part of the health system officially. So we can speak about all those solutions, but we need to also ensure that they're officially part of the health system, community system, health actors, community actors, making sure not only they're part of the health system, but they have a recognized status. So if I only take the example of community health workers, how many of them have a recognized status in our country, and how many of them are recognized by our health policies? Yes, they are a critical component in malaria community health system and governance. But yet, when we look at the health system, we look at the status, we look at the health policies, we don't clearly see how they are represented. So my contribution to the paper will be, and then to the speakers, great recommendation would be to make sure that in our health system, in our African health system, we do recognize those community systems. We also do make sure that we allow the budget line for investment at the community level to ensure that those systems are supported, are capacitated, and they are able to contribute, and they are able to also raise all the issues around access to services to malaria, which are not only financial access, but also cultural access, also language access, also all the different other reasons that prevent communities to have access to quality health services. So I think it's a very important topic that should be on the table, and we hope that as country will review the strategic plan or will develop new malaria strategic plan, we will see new approaches and new strategy, new elements like community health governance, like community-led monitoring system, like community system strengthening, like all those components involving civil society and all the other community groups that are well presented and who in the strategic plan, but also in the health system, and that are also given a status so that they are able to receive great investment. Thank you.
Thank you so much, Olivia, for your contribution. I'll just give Dr. Lee Coleman an opportunity to respond after I introduce the next speaker. I would like to invite Felix Ongera Mogaka to comment on Dr. Jessie Barb's presentation. Felix is a research scientist at the Kenya Medical Research Institute. Felix, over to you, and thank you for being here.
Thank you so much. Good morning and good afternoon, everyone. And I also want to thank you for inviting me to participate in this forum. I also appreciate the enormous work that you're putting into towards the elimination of malaria, which includes organizing such webinars. So I'll make 3 brief observations, and these cut across what has been presented today by our first 2 speakers, and also on what we covered in the first webinar last week. So I'll start by first observing that malaria should not be considered only in the context of COVID-19, but also in the broader context of other communicable and uncommunicable diseases, and as well as in the context of social determinants of health, which have been elaborated, such as economic and political stability, access to education and employment, nutrition, the environment, among many other things. I am also very happy to note that this forum, in the last webinar that was here, identified that countries that have eliminated malaria recently, such as China, have not done this as an isolated event, as you could see in their response towards COVID-19, and also in the number of people who have been lifted out of poverty over the last half a decade. So this means that in order for the regions where malaria is still very prevalent, and especially here in Africa, for them to sustainably control and eliminate malaria, they must also be in a position to eliminate poverty and other diseases such as HIV, as well as to be prepared to adequately respond to emerging diseases. The focus must therefore be on improving the entire healthcare system, which is what the first speaker calls primary healthcare system, and not on isolated responses to specific diseases, one at a time, and mainly based on global health funding opportunities. The second thing that I noted from the first webinar, and that has been highlighted by the first speaker as well and the second speaker, is the role of community engagement. And I think it has been unanimous that we need to go to the communities. The risk of this, however, is that we may end up with a bureaucratic ritual, ticking a checklist of community involvement. So decolonize. From the case of Sri Lanka, I mean, one of the things they pointed out was a strong community engagement. But what does community engagement mean? It does not mean only setting up ad hoc committees that are there to be consulted and to give consent, but it means having multidisciplinary community-based teams that include individuals with the capacity and resources to collect data and to act on it. One challenge is that the kind of decentralization that happens goes against the prevalent top-down approach that has been inherited from colonial administration of looking up to experts who are often in headquarters, making policy decisions, which are then implemented in the peripheries. So community involvement or decentralization of malaria response cannot be only devolving duties, but also policy making involvement. Additionally, the data the data and management and having the local teams respond to collect data and respond to it has also to come with investment, because newer and newer ways of responding to crisis, and this includes fields such as implementation science, translational sciences, are developed and are largely based in academic institutions in the global north. Therefore, you cannot just ask local people to take up the role of being experts in dealing with their local issues without acknowledging that they are, from the word go, alienated from the tools and from the development of tools and methods they are expected to employ in dealing with this pandemic. So, as the authors of the manuscript that has just been presented rightly observe, that without an endless cycle of data for academic institutions in the global north to work with, and for new global health entrants to train with, global health research as we know it today would be unrecognizable. To truly decolonize malaria response, resources have to be brought to the closer to where the problem is, and not in institutions in the global north. Thirdly, something that's important to note is even as we think about a new way of doing things, we need to ask ourselves a fundamental question of what it means to really decolonize global health. Do the local people in the communities have sufficient privilege, such as we have here, to discuss this? Do they have the academic, historical resources and structural context of working in both the on the ground and also within the structures that are controlling these? They have all these background to appreciate the contradictions that are framing this discussion in the way that has been presented by our speaker, for instance. So it's important to recognize that the education that we have to respond to malaria, all the tools and methods that we have were designed to make the people that we look to eliminate malaria, the education was designed to make them work within the current system that we are questioning. So I want to say that colonial education systems and working environments will not produce the solutions that we seek. The process of decolonization, therefore, is going to be long, and it's going to be iterative, because colonial legacy is embedded deeply in the communities as it is in the institutions that are leading global health today. And lastly, I want to add that to reflect on colonial legacy and its influence in our decision-making should not be an independent and an isolated inquiry, but this kind of thinking should go into every working group, something that we are doing well. So these are my observations, and thank you so much for this opportunity.
Thank you so much, Felix. That was a really great presentation. I do particularly like your point about, how you acknowledge the fact that decolonizing is going to take a long time. It's a very complicated conversation, and it might take, decades to unpack. I will like to invite Dr. Nee Coleman and Jesse Barb to comment on the presentations by our discussants. Dr. Nee?
Thank you. I'd like to respond to 2 comments. Olivia made some very fantastic points. And the first one was about investment in the community. And I agree with that wholly. To do that requires change right from the top. That is why, for me, global agencies shifting from medical approach to social determinants approach, acknowledging that malaria is a social problem, that will change the structure of their interventions. That immediately calls for community response, a broad component called community response, which should then be a budget line that should channel funds to the communities. The second point is about community health workers. I speak mainly from my experience in Ghana and Nigeria. I worked for 18 months in Nigeria, but I believe most African countries have, since independence, been developing primary healthcare system. In the 80s, I worked as a district medical officer of health. I was involved in training of village health workers, formation of village health committees, and training of TBAs. I think our health system has moved forward. Now we are talking more about supervised deliveries rather than TBAs. I was also involved in the impact evaluation of TBA training, and we found that there was no difference between mortality rates of mothers who attended trained TBAs as against untrained TBAs. So in the 90s, we proved that TBAs have no impact on maternal mortality. Look at the causes: hemorrhage, abortion, infections, toxemias of pregnancy. Which one does TBA influence? None. So not surprising that TBA training does not impact maternal mortality. That's why we are saying that let's still be in the community. We have village health committees. They are all around. Some are defunct, some are functioning, but let's reorganize these passive village health committees who are only waiting for breadcrumbs on the top into a multi-stakeholder group in the community which talks about their problems. Why are our children dying from malaria? Start from a basic question and it will snowball into their taking part. Of course, not all African countries have systems developed at the local level, but we have all been championing primary healthcare. So these structures should be there in one way or the other. There's no other way. Get the communities involved. Don't kick out the medical people. If it's our community health governance, it's the frontline medical workers, the women's group, religious organizations, youth groups, traditional leaders, elected community members of community. All these people within the community coming together. There's also a lot of resource. I'm a retired person. When you go to our villages, a lot of retired people, educated retired people in the villages who can be tapped to champion this discussion. And they have the concepts and tools to engage in these discussions. Let's not take our villages to be full of uneducated people. There are a lot of retired people going back to village settling, looking for opportunities to serve their communities. There are resources within the community. Thank you.
Thank you so much, Dr. Nee Coleman. I would like to invite Dr. Jesse Barb to also have an opportunity to comment on Felix's presentation.
Thank you, Ify, and thank you to Dr. Mogaka. I think these comments in this discussion is really important. In fact, its importance is difficult to overstate. I think some of the things that Dr. Mogaka is asking for are an emphasis on development and not diseases. And in so calling, he goes against the basic tenet of colonial medicine. And that was to divide things into diseases that suited the specialties of colonizers. When we tell narratives in global health, in fact, I defy you to find a single global health report that doesn't begin with a line about the severity of some disease. It will say whether it's malaria or anything else, the burden of this disease is tremendous. And then it usually says the vast majority of this burden is found in Africa, We have created as a community this sense that malaria and other diseases are features of nature. In fact, we need to think about how humans cause this problem. These are colonial problems. These are problems and diseases that were spread and that were worsened by colonization. These are products of extraction. And if you just look at the disease, it's hard to see that. And just looking at the disease means you can't see a solution either. That brings me to the next point. Over in the chat, some people have asked about research. And I said, well, you know, what do you really need the research for? As a researcher myself, I love research and I'm a curious guy, and you could talk me into answering almost any question. But the fact is, for basic malaria control, we don't really need research, and we certainly don't need the kind of research that is predominant at northern institutions. So, you know, malaria disappeared from many places because of environmental modification without the benefit of hundreds or thousands of papers. I think some good old-fashioned field work is important. Things like swamp drainage, housing improvement, community involvement, activism. I find it really difficult to believe that there are endemic villages in the sub-Sahara filled with people suffering from malaria and just waiting for some person to show up and do some research on it. It just doesn't make any sense. And when you start asking what is our research doing, it leads you down these pathways of trying to understand, how do you create an ongoing role for colonial pathways in a world that doesn't need them and is harmed by them? I'd like to ask these questions as a way of trying to recenter the ideas of malaria. It's a problem that was caused by colonization. If you look at histories of malaria written by global health people, they will talk about it as a disease of antiquity. And in fact, yes, it is. But the malaria we know and we see in sub-Sahara, it's not a disease of antiquity. It's a disease of colonization. It's a disease of the inequality that colonization created. And part of sustaining that inequality is why the global north continues to extract knowledge and resources in the form of research projects. I think that has to end, right? It's time to redistribute. It's time to answer questions that people actually have. And the people who can answer those questions, they're people who speak those languages, who know those communities, who come from those cultures. They aren't people at distant metropolitan institutions. So I thank everyone again. I thank Felix for his comments.
Thank you so much, Dr. Jesse, for your contributions. I've got a few questions. We do have 5 minutes left, but we've got questions from the audience, and I will be asking, maybe we just have time for 2. So one for Dr. Nee, how are community health workers involved or not in the malaria programming in Ghana? And if you can keep your answer to 1 minute. And then to Dr. Jesse Barb, Farah Shroff is asking how to support African scholars and institutions to take the lead in malaria and also transform existing malaria institutions to be more focused on solving malaria in Africa. Dr. Lee, have you got, you've got 1 minute to answer the question, if you're on.
The main involvement of community health workers is in the distribution of insecticide-treated bed nets. They are in the community, so they act as the link between the health system and then distribution to the community. So the distribution is channeled at the community level, is in many instances channeled through community health workers. And they are those who identify eligible people for distribution. Basically that.
Okay, thank you, Dr. Nee. Really quickly, Dr. Jesse, 1 minute to answer the last question.
One minute to decolonize malaria. That's a pretty tall order, but you know, this question about what steps do we take, or how do we ensure that African scholars lead efforts, it's like they're there, you listen to them. And if they ask questions, we help them. You know, on this panel, we have friends and colleagues. I have friends and colleagues, and I've been delighted to work with them. I've been delighted to work with many Africans, but this is not an exercise that should create or reinforce inequality. We need to redistribute our resources. So when you talk about decolonizing malaria governance, it's about shifting the locus of power. It's not about diversifying the people in northern institutions. It's about reducing the relative power and their relative importance in a discussion that just doesn't affect them.
Thank you so much, Dr. Jesse. Felix, you want to comment? Can you keep your commentary to just 1 minute, please? That's all we have time for.
Yeah, very sure. Thank you. I just wanted to leave us also by saying that community involvement does not mean going back to rudimentary tools, and we should not put community involvement on one hand and advances in science on the other, because scientific methods are not unique to any culture and they are universal. Therefore, community involvement, we should not look at it as, bringing we should also look at it as bringing good expertise of epidemiologists, of top physicians and everything to the ground as well, to deal with these issues, and not just involving the people on the ground who are already there and making them experts. Thank you.
Thank you so much, Felix. I just want to use this opportunity to thank all our presenters for being here. And I hope that we can have this conversation out of this session. Decolonizing malaria is going to take a lot of, decades to do, but we should still keep having this conversation. I'd like to pass on to hand over to the next session, Camille Mendes, who will be facilitating the integrated service delivery for malaria. Thank you everyone for tuning in.